Thanks very much. Welcome, everyone. It's great to have you here, and thank you for joining this webinar. So I'm just going to start us off just by a short introduction. A lot of you will hopefully be familiar with the COPE study, and I know you'll have participated as and helped us with the questionnaires and the various study aspects of this. But just to give you a little bit of a reminder and a background, I'm sure that everyone is very familiar with the study, but I'll start with just that background, like I say, and then we're going to go into a few people who are going to speak to us. So we've got Sarah Burhane, who's going to feed back some of the initial survey findings and what we're planning to do with all those questionnaires that you filled in. Chris Poyner is here, who is going to talk to us about the interviews and some of the findings, initial sort of findings, and how we're going to move forward with that. And Alex Richter will speak to us about some of the blood tests. Sorry, I put timings on some and some on others. And finally, what I'd like is a discussion for all of us who are here, just to help us to think about who are the people that we need to more widely inform the findings of this study to. So where should the findings go, and who are the people who can act on this? So many of us will be familiar with these daily graphs that we get, and this is the background to the study, is that we have had increasing cases of COVID, and this is still ongoing. This is data from the UK, and the most recent data that I could find from yesterday, showing weekly rolling averages of cases of COVID. And we also know that not only are the cases continuing to happen, but there has been a higher rate of COVID in healthcare workers. So the risk of infection in healthcare workers is higher than that seen in the general population. So that there have been a number of studies that show that there's between 3 and 7 times higher risk in healthcare workers. And this graph is just showing that again here compared to other essential workers. Healthcare workers have been affected more, and their healthcare workers and their household members have contributed to 1/6 of all hospitalized cases. What we don't know yet, and that's partly what this study is about, is the extent to which workplace and related risk compares with other risk factors to somebody coming down with COVID. And within the workplace, what are the factors that are contributing the most risk? So the aim of the COPE study is to examine the relative contribution of occupational compared to exposures in non-occupational settings on the risk of COVID in healthcare workers, and the factors within the workplace that are contributing to higher risk. And also, more importantly, how can we minimize this for the future? So as you probably are aware, the study included a questionnaire, which many of you have completed, and a follow-up survey 4 months later. There have been interviews with a sample of some of those who've completed questionnaires, blood tests, the dry blood tests that have been sent out, and a subsample of those who've participated are also taking part in our household member sub-study, where we're asking household members of healthcare workers who had a positive antigen result to do some blood tests and fill in questionnaires. So that's really just the background, and I will stop sharing. I'm going to move on to invite our first speaker, but before I do, Katie is kindly just going to explain some of the housekeeping and how we're going to manage the chat, if that's okay.
Hi everyone, thanks for registering to attend the webinar. It's really great that you're interested in seeing what findings have come up so far. If you have any questions for any of the speakers, you can ask a question in the Q&A button at the bottom, and it's set so if you can view the questions, you can comment or vote on people's questions if you see something in there that you think is important or interesting to you. So that'd be really great. We've got some people here to monitor questions, so if you type anything up in there, they will raise it to the speaker and they'll answer in the discussion period after the presentation. So
thank you very much, Katie. That's great. So I'm going to hand over now to Sarah. So please do keep comments and questions in the chat. If we can't answer them in the session, we'll do that later. And Sarah's going to start us off. Thank you. Sarah, you're on mute.
Sorry. I'm still on full screen. Can you hear me now? Oh, cool. Sorry about this. Okay, so hi everybody. I would like to start by thanking everyone who participated in this study and taking the time from your very busy schedule to fill in this very extensive questionnaire. We are really grateful. In this talk, I would like to give a brief summary of what was collected and an overview of an analysis plan. We had 2,642 participants, and this table shows the breakdown of the occupations. There were a range of percentages across the different occupations, but the ones with the biggest proportions came from paramedics and nursing staff. Similarly, for departmental breakdown, we see that the biggest contributions came from the emergency medical unit, office space, and other departments. And we also looked at sex, ethnicity, age, and highest qualification breakdown. And the participants broadly represented the trust staff. However, there was less success in recruiting staff from ethnic minorities. And the table on the left shows the results from the self-reported antigen tests. We see that over 25% of those were reported as positive. And the figure on the right shows the number of antigen tests over time for each of the negative and positive results. For the negative results was a steady increase in the number of tests across across different times. However, for the positive tests, this increase was more like in a stepwise fashion, with bumps seen at around mid-April and January, coinciding with the pandemic peaks. And as expected, the rate of positive tests plateaued after February when vaccination rates increased. And just a reminder of the questionnaire sections. There are 8 sections with questions regarding the participants, the COVID-19 infection and testing experience, as well as exposures outside and in the workplace, and other factors like lifestyle habits and home situations and so on. Now, with regards to the analysis plan, we would like to investigate the relative importance of certain exposure settings in the risk of COVID-19 infection. So the first 3 listed here relate to settings, occupational settings, related to staff contact, as well as contact with patients with or without suspected COVID. Whereas the last 4 look at non-occupational settings, such as indoor social gatherings and public transport. We also look at other factors that may contribute to the risk of COVID-19 infection. These are like socio-demographics, home environment, lifestyle, and clinical characteristics. For each settings, we also like to examine the role of various occupational and non-occupational exposures and the corresponding protective measures in the risk of COVID-19 infection. Examples of exposures are such as COVID-19 patient contact, COVID-19 materials and surfaces, body fluids, aerosol generating procedures, indoor social gatherings, and public transport. And for each of these exposures, there are recorded protective measures such as face mask, gloves, hand hygiene, and plastic apron. As you know, the questionnaire derives quite a lot of information. So for the purpose of this talk, I'm going to focus on the direct contact with suspected or confirmed COVID-19 patients in the 2 weeks prior to the test. And this will be given as in terms of dose, that is the number of patients in close contact, duration, that length of close contact, as well as we also look at PPE, specifically single-use face mask, disposable apron, and gloves. So we had 684 positive results and 1,628 negative results. And looking at the these particular percentages, we see that those who were positive had, well, 42% of them had direct contact with COVID-19 positive patients, whereas this was 23.5% for the negative self-reported negative tests. Hence, those who had positive tests were more likely, those who had positive tests were more likely to provide direct care to patients with COVID-19. Similarly, we're looking at the dose, i.e. the number of COVID-19 patients in close contact. We see that overall, those who were positive in the tests had higher number of contacts with COVID-19 patients compared to those with negative tests. This is specifically notable in the higher categories, say 5 to 10 to over 10, where you see that the percentage more than doubles in those who are positive compared to those who are negative. And similarly, for duration, that's the maximum time to spend close contact with COVID-19 patients. That's also the same message, where those with positive tests had longer contact with COVID-19 positive patients compared to those who are negative. And this could be, so you can see that specifically, this is more clear with the 5 to 15 or the over 15 minutes contact, where the percentage were again nearly double of that in the positive compared to the negatives. We also looked at PPE whilst providing direct care to COVID-19 patients. We excluded those who do not go to workplace and did not provide direct care to COVID-19 patients. And overall, we see that those who had a positive test were more likely to use face coverings, as demonstrated with the percentages here, with 68.1 versus 56.4%. That's similarly with apron, you also see a higher percentage of those who report always using apron wear in the positive compared to the negatives. And the same with the disposable gloves. But I'd like to remind everyone, obviously, this is an ongoing analysis, and there are other factors we have to take into account for the analysis, like other factors that may adjust, other factors that adjust as well as missingness. So yeah, this is still ongoing. I think that's my final slide.
Thank you. Thanks very much, Sarah. That's a nice, interesting sort of glimpse to the rich data that's being collected. I wonder if there's been any questions. Anybody have any questions before we move on, or any comments? I see that there is a question about the recording being sent round, which I'm sorry, it's if you're missing some of this, yes, we will be sending the recording round to those who participated. Okay, thank you. If there's no questions, and we can always come back if anyone wants to think about this and has any thoughts later, we'll have an opportunity to ask again later. But maybe we can move on to Chris and sort of chat about the qualitative studies.
One question has just popped in, Pamela.
Sorry. Oh, apologies. Okay.
Sorry, so this is Diana, one of the research nurses. So the mass result is odd. Did you ask which type of mask was used?
This says single-use face mask. I think this is the disposable mask. But there are other, I think there are other, sorry.
Yes,
So we've got details on a range of different masks in the workplace. But yes, this is, I think you're right that it looks odd in terms of you'd expect it to be the other way around. But I think it's partly that people with more contact would have been using these equipment more. And the next step will be to try and adjust for the different risks and exposure and protective measures so that we can tease out a little bit about which of those protective measures were more important as well. Sorry, Sarah, to talk over you.
No.
Okay.
And another question has just come through. It's how do you discriminate between vaccinated and not vaccinated?
I guess I'll answer that when I get to, that's part of why we're doing the antibody testing, and we've also got the data around that. So we've been looking at how we can analyse that going forward. So maybe I can explain that a little bit later.
Thank you.
Okay, if there's no other questions at the moment, we can move on to Chris. Yeah.
Okay, yeah, I'll share my screen now.
Thanks, Chris.
Okay, and we'll get started. Again, I'd like to echo Sarah's thoughts. Thanks so much for your participation, supporting us with this study. We're extremely grateful, and without you guys, obviously, wouldn't be possible. So many, many thanks. I've called this a qualitative member check, and what that means is we want to present today to give you a sense of the data we're collecting. It is emerging currently, and we are still collecting data. So the idea here is that we present some initial kind of themes and findings, and we want to get a sense check to see what you guys think. So please do leave any comments. If anything you see rings true of your experience, then please leave a note about, or if there's anything different that you think we could be picking up on, but that you've experienced or your colleagues have experienced, then do leave that in there as well. So to give you a sense of the overall kind of large overarching kind of areas that we've got themes on to present today. So we have infection control processes at work. So obviously things like PPE and social distancing and how they were introduced and whether that was satisfactory or not. Then we have communication and work processes following infection. So that's when you've been infected with COVID, how work dealt with that and how the communication was, and also on return to work as well. Then general experiences of working during the pandemic, the impact on mental health, and then some thoughts on vaccine rollout and vaccines themselves. Okay. So as I said, if there's any other areas that you think aren't captured within these headings, obviously these are quite broad headings, please do let us know in the chat anonymously if necessary, that's fine too. So to start off on infection control measures and processes and PPE at work. So the first theme here that's coming out quite strongly is that at the beginning of the pandemic, so we're going back to the start of 2020 here, infection control was poorly implemented. So a lot of the participants have used words like chaotic, there being no masks to begin with, and that not being mandatory, that being quite a controversial thing at the time. Obviously masks were introduced later on, but also no social distancing, and anyone not really knowing how to deal with infection control in a pandemic, largely because it was unprecedented and that we weren't really prepared at kind of a national level or a trust level. So the little comment I've got here is it came a bit too late for the majority. So the idea that infection control was implemented, but it was too late for a lot of people who had already contracted COVID-19. So moving on, acceptance of infection control despite discomfort, extra workload and inconvenience. So the majority of staff I spoke to, and well, Emma and others who did the interview spoke to, said that they were quite happy to wear the PPE and to stick to guidance, despite the fact that it was somewhat inconvenient, but it would add to the workload. For example, when doing extra wiping down work or having to walk further due to social distancing, and obviously wearing a mask 24/7 isn't the nicest thing to do either. So there was a large acceptance of having to deal with all that, and everyone was happy to do so. Okay, so it was all unknown, wasn't it? So the high risk of infection as unavoidable to begin with. So this is just highlighting what I talked about already, that because of the unprecedented nature of the pandemic, there was acceptance that there was going to be a high level infection, and there wasn't as much anger prevalent or tangible in people's narratives as perhaps we may have been expecting. There was this kind of acceptance that this was something that was going to be difficult to avoid. And I think there was knowledge from staff that they were going into environments where they may be infected, and that was something that they had to kind of deal with and come to terms with and accept. So there's an element of sacrifice there for the greater good. Okay, so yes, as I've been saying, infection control measures were implemented effectively after the initial period. I feel that this kind of quote kind of highlights that quite well. So when they did roll it out, they were very thorough with what they had to wear and provided it. We've always got enough. I've never heard anyone say we've run out. So this isn't true in every example, but the majority of participants suggested that as time progressed and as the pandemic kind of went forward, PPE was much more widely available than it was at the start, despite the fact that perhaps there was one or two instances where that wasn't the case. Okay. So experiences of communication and work processes following infection. So initially, once someone had reported symptoms to their work or to their line manager, majority have talked about work being very supportive, so arranging things like PCR testing for them, obviously adhering to the periods of leave necessary, ringing up during the periods of isolation to make sure that people are okay. So overall, that was quite good, I think, initially. There was an issue for a minority of staff where there was like an investigation into their COVID if they had symptoms at work and there was an outbreak, and that was quite challenging for people while they were recovering. So there was that issue. The area of most dissatisfaction, however, was returning to work. So that was seen as quite challenging by some participants, not all, but some who perhaps were still dealing with fatigue or some longer COVID symptoms felt that perhaps they could have had some things implemented upon return to work to make that return and that transition just a little bit easier. Okay. So experience of working during the pandemic. So the first theme here is demand as outstripping capacity. So certainly during the peaks of the pandemic, the majority of staff, certainly patient-facing staff, discussed how it was extremely demanding environment, not only due to capacity issues, but well, because of the volume of patients they were seeing, but also because of staff being sick leave themselves, or because staff had left, so that there was a high turnover of staff. And actually the patient groups that they were dealing with were quite traumatic as well, and that being quite difficult to deal with too and quite demanding. Moving on, the restrictions on family visitors as challenging. So the idea that families couldn't come in, that was causing some difficulties in terms of palliative care and being with people at the end of life, but also in terms of the volumes of phone calls to the wards, and that being hard to deal with, and perhaps that not being addressed appropriately by the trusts. And also peer support is important at work. So staff saying that it was good when they had strong relationships with their colleagues at work, and that was quite a big protective factor for their mental health when they were working during the pandemic. Morally challenging decisions in the workplace. So this is the idea that at times staff had to make decisions or perhaps break, for example, social distancing guidance, or felt they had to do so because of how challenging it was working in that environment, and the need to have some empathy with fellow staff members, and that sometimes involving physical contact. So for example, if there'd been deaths amongst the staff group or with patients that they were caring for. So yeah, this idea of, okay, so we have to stick to the rules, but at times we make decisions that go against the guidance. Another example is paramedics who may have been rushing to help patients in the community without the level of PPE or making that decision to put PPE on or go in and help someone, and having to do that at the split second, that being quite a morally difficult thing to do. There was a lot of data on redeployment experiences that range from really positive to quite negative. One thing that was quite prevalent was the idea that there was no choice or knowledge about when staff are going to be redeployed, and that being quite difficult, and a lack of flexibility around redeployment as well. So, for example, not being able to be redeployed to somewhere local to where you live, perhaps, and that being difficult in terms of public transport. And there are other examples within that too, but we'll have to move on. So the impact on mental health. Mental health was reported by the majority of participants as getting worse during the pandemic, and even for some who hadn't experienced poor mental health outcomes related to their job before and didn't have felt quite resilient, did say that they felt their mental health had declined somewhat. One of the reasons for this was the uncertainty that the pandemic created, and there's various layers to this. So, for example, there's the uncertainty around getting COVID. Am I going to get COVID or not? And if you do get COVID, the uncertainty of your health outcomes related to that. Is it going to be serious? Am I going to be hospitalised? Will I have long-term fatigue? These kind of things play on people's minds and affect their mental health. And also just the uncertainty about how long COVID and the pandemic was going to last for, and that being quite mentally tough to deal with, and being no end date in sight for this period of time that we've all been going through. Another issue related to mental health was coping mechanisms being disabled by the lockdown context. So the idea that staff were going home after a really difficult day and not being able to escape it in the way they normally would during times previous to the pandemic. So some examples were, going to meet up with friends, going to the cinema, taking annual leave really effectively, traveling, these kind of things were all disabled, seeing family as well as friends. So that was a big drain, I think, and something that came across both in terms of patient-facing staff, but also our admin staff and people in staff in call centres and such. Finally, I just wanted to touch on working from home. So obviously working from home seems like a protective thing, but actually what we've been finding in the interviews is that to an extent, some participants felt that was quite difficult for their mental health. And again, I think part of this is to do with the lockdown context as well, because if you're working from home, obviously you're having that issue of not being able to do the things that you would normally do to cope, but you aren't going to work either, so there's no change in environment at all, and you're not engaging with your colleagues, so the human-to-human contact was very minimal. But there was also this idea of guilt about not being able to go in and help for those who were vulnerable and were shielding, that they really struggled to come to terms with. Oh, sorry, how do I go back? Previous. So I also just wanted to touch on vaccine perspectives before we end. So the majority of staff were very pro-vaccination and didn't have any hesitancy related to it. So yeah, this quote here, my views on vaccines, I'm telling everyone to go and have the vaccine. That was quite a common response. There was no anti-vax kind of sentiments really, but there was some vaccine hesitancy for various reasons, two of which I've highlighted here. So one was the concern that it wasn't a well-researched vaccine and that the vaccine had been developed quite quickly. And another one was like a principle aspect, where it was a case of being concerned that it wasn't, a minority of staff didn't feel it was their decision to get the vaccine, and that created a little bit of hesitancy as well. Okay. So that's all I had to share today in terms of the qualitative findings. There's a myriad of other elements to this, but just wanted to highlight some of the key things today. Thanks very much for your time and attention.
Thank you very much, Chris. So again, as Chris said, just to reiterate, this is still preliminary and we're still collecting data. So some of this may change, but if anyone has any comments, particularly any areas where you think we don't seem to have picked up on, you're surprised that we haven't touched on, we'd really be grateful for you sharing those thoughts. We'll also potentially be contacting a number of people to see whether we can gather a group to have a discussion about these findings. So you may well hear from us just to ask, so a discussion to help us to shape the findings in a way that can help us to find actions. What should we do about them, and who are the people we need to talk to make sure some of these findings don't just stay as interesting data, but move to something that we can do something about. So again, you may hear from us to invite you to take part in that. Any questions, Di? Sorry.
So there's no question from the audience, but we actually have a question ourselves to Chris, if that's okay. So,
yeah, shoot.
Thanks, Chris, for great presentations. My question would be that did you compare the themes based on a workplace, for example, ambulance service compared to hospital, or ITU compared to ward? Was there any difference in there?
Yes, I think the main difference would be whether staff are patient-facing or not. That seems to have really impacted the experience. Obvious reasons in terms of the kind of risk of infection was a lot higher and perceived to be a lot higher for those who are patient-facing, and that and the workload, especially for kind of, I guess, like, you know, quote unquote frontline staff was really quite strong as well. I think with some of that administration staff, the lack of contact with colleagues was difficult, both in terms of on-site if there was social distancing, but a lot of the admin staff were also sent home to work from home the majority of the week, if not entirely, and that was quite strenuous, particularly for those living in more cramped social housing. So those with kind of outdoor environments available to them, like gardens and such, they actually did talk about how great it was that we had good weather during that first lockdown in 2020, that being a really protective factor for their mental health. And then, you know, the minority of staff I spoke to who were working from home all the time, living in like flats and stuff, said that was really tough. So there's some of the kind of just one of the difficulties with it though is because we had quite, you know, we've got I think around 40 interviews done so far. It's quite a small amount to start kind of dissecting it into smaller groups. So, you know, like 5 paramedics here and 5 nurses here, 5 call centre workers here. So what we try and do is look at what's common across the data set, but also, of course, teasing out some of those real key differences that I've just discussed.
Thank you.
Thank you.
The next question is, did anyone comment about issues where they felt like they were being bullied or their grade was reduced because they were no longer able to do the jobs that they were employed to do?
Oh, that's an interesting question, thanks. Not explicitly, but there was concern around redeployment, and there was concern about how redeployment might impact career progress and prospects. One issue with that was line management, so not having clear pathways to line management, or line management not being clear enough, and what if I've been redeployed for, like, you know, 18 months or a year in a completely different field, how is that going to impact my career prospects in the field that I'm a specialist in? And I think they were some of the concerns that staff had in relation to, you know, future salary, for example, future job prospects and career prospects. In terms of bullying, there was the issue that I discussed in terms of when staff got COVID in the workplace, and there being an investigation into that was seen as quite stigmatizing and quite challenging at a time when people were recovering from illness. So that might be something that, when we look at the recommendations coming out of the research, we might try and think about, you know, how can we best relay that information on to people in charge, and how can they perhaps deal with those issues in a little bit of a better way. Sorry, that's not. So yeah, go on. Sorry, Diane.
The financial cost, because some nurses, for instance, might do unsociable hours, and if they have to now no longer do any patient-facing duties, then did anyone mention that their income was suddenly compromised?
No, that's not come out in the interview at all. It may just be because of who we've spoken to, okay. But I'm fairly sure that hasn't come out, certainly prevalently within the data.
Thank you.
Thank you. We don't have no more questions, so that's it from us. Thanks.
Thank you.
Thanks very much. That's excellent. Again, a reminder that if anyone does think of any questions or wants any comments, please do use the Q&A and the chats, and we'll record those. Thanks very much, Chris, for that. If there aren't any questions, then we'll move on to Alex then to talk to us about some of the blood test results. Thanks.
Thank you, Pamela. And thank you, Chris and Sarah. I mean, certainly those were some very powerful testimonies that we've just heard. And I'm very mindful of the fact that this hasn't finished, and that these are ongoing experiences that all our staff are dealing with. So my role in the project has largely been around the antibody testing. And you will remember that you've all been doing these little dry blood spots, like the heel prick tests in the community. And I just wanted to show you how we've been using them and why we've done them, and then how we're going to use them with the other information to do our analysis as we go forward. So why bother measuring antibodies? You know, Sarah's just mentioned that we've done what's sometimes called the antigen test. Sometimes it's PCR, sometimes it's a lateral flow, but it is some way of detecting live virus and that someone is unwell at the time. Now, what I do is measure antibodies, and what antibodies measure is that you've had some kind of immune response to this virus, and that can either be to the live virus, or more recently, it can be due to the vaccination. So what antibodies tell me is they can determine who has and who hasn't suffered from COVID infection or vaccination. Now, this is really, really important, especially when we set up the study, because very many of you had infections early in the pandemic. And those that had early infections, there was no access to PCR testing. And so the only way of working out how many of you had had infection for the first few months was retrospectively using antibody testing. And the other thing that we found out about, you know, by about kind of May, June, we were working this out, just the sheer rate of asymptomatic infection. And of course, if you're well, and we're not screening for infection like we are now with the lateral flows, we don't know who's had it and who hasn't had it. And so the only way of picking that up was with antibody testing. And actually, these graphs I show you here show in the first part of the pandemic, the number of cases of COVID were really low compared to deaths. And that just tells us that we weren't doing enough PCR tests. So we don't have enough PCR cases. It was much better in last winter's wave because we had PCR testing up and running. So you can see that there's a much better match between the number of cases and deaths. And then really interestingly, going through to this summer, it hasn't quite gone through to the autumn, but we've got, again, high numbers of cases, but much lower numbers of deaths. And that's obviously because of vaccination. So actually, in terms of detecting who has and hasn't had COVID, an antibody test is overall much more sensitive than an antigen or a PCR test. So some of you will remember these swabs, these spots. And why did we do it like this? Well, to be able to bleed you all in hospitals, you know, take you away from the workplace, arrange a time, arrange more PPE, we felt the best way of doing this was allow you to self-sample and get the sample to us. And we'd already done all the work in the background to show that it doesn't matter whether we do your COVID antibody testing by dry blood spot or we do it as a blood test, we get virtually exactly the same results. So we're really happy and confident that we're getting a good result on this. And the assay, the test that we've done the COVID antibody tests on, is a really, really sensitive assay, which is why some of you have had a few questions during the study as to, you know, why was my healthcare worker test different? Why was that negative if I did that in hospital, but it was positive on your test? Our test was designed to detect asymptomatic and individuals that had had mild infection. So what we were really working on was that bottom end of sensitivity. And because for this study, COPE, we were looking at largely individuals who had had mild disease, we wanted to use this really highly sensitive assay for detecting antibodies. So now I just want to show you a little bit about how we can use antibody results in the analysis, and just a few very preliminary observations. So what we've done is looked at our antibody rates, either pre-vaccination, which started second, third week of December 2020, and then after vaccination and our individuals that recruited. So the COPE study, as you know, covers that pre and that post-vaccination period. And this is something we will be considering in the analysis. So there are two ways we can identify this. One is because you thankfully all filled in your questionnaires and you've told us about vaccination, but also we can look at your antibody rates compared to what antigen testing or PCR testing you've had done, or your self-reported symptoms of COVID. So we can tease all this out. So what you can see is prior to vaccination, it's about 46% of all our participants had been exposed to COVID, and this is COVID natural infection. So this is most likely to have been to the original Wuhan strain, and then the Kent or the Alpha strain last autumn. And this is much, much higher than the general population. Which rates at this point would be running at about maybe less than 5% of the whole total population. So we already know that our rates are much higher, and we've shown this before. And then what's really exciting to see is that from December 2020 to April and then May 2021, antibody rates, which are our best marker of who's likely to have the best protection against COVID, goes from 46% to over 98%, which is just absolutely fantastic. Now, unfortunately, just because you have antibodies, it doesn't mean that you are definitely protected against COVID. We know that the vaccines, both Pfizer and AZ, have much reduced protection against Delta. And that's why we've all been offered the booster this autumn. And that's why we still wear our masks, and the PPE is still all appropriate in the hospital environment. So we will continue to monitor that. What I was interested in a little bit was antibody rates pre and post vaccination. And so I split up the data according to this pre-vaccination period and this post-vaccination period, just to have a quick look see. We could do some of the in-depth analysis to try and bring these groups together more clearly. And I can see that there is a group in the post-vaccine period where individuals are seronegative, and that means that they don't have antibodies. So what I didn't know was whether that was because not all our healthcare workers responded well to vaccination. Is there a problem in some individuals with responding to vaccine? Or is it just because they haven't been vaccinated? So I was then able to go back to your questionnaire data, and we were able to look in general at the total number of vaccine rates in our healthcare workers. And you can see at recruitment, 84% of all our healthcare workers had had 2 vaccines. So we're essentially fully vaccinated. We had 9% that had had only 1 dose at this point. And then there was 7% that were unvaccinated. So the take-home message for this is that if you've been vaccinated, you were highly, highly likely to have produced antibodies against the vaccine. Unfortunately, that doesn't, necessarily stand true for protection against Delta, but that's why that top-up dose and boosting those antibody levels as high as possible was so important. And then how can we then integrate what we know about testing? So what we know about your antibody status, we can then work out whether you've had infection or not. We can then look to see how this information has been influenced by some of your occupational factors that Sarah's spoken about. And we looked at this a little bit in a study that we did prior to COPE, and this kind of informed our COPE study. This was a study we did at UHB right back at the beginning in April of 2020. And it was there that we were able to detect that healthcare workers had such a high rate of infection. But intriguingly, and we will tease this out in our analysis, we assumed it was our intensive care staff that would be at the highest rates of infection. But actually, it was our housekeepers and our porters and those that potentially were seeing patients with COVID, but without the high levels of PPE that our ITU staff were using. So those original findings, we can now look at what's been found in the literature and look at our testing, and then look at all the factors that you've responded to in the questionnaire to really understand who is at risk, but then also how our PPE measures are able to protect us in different environments from contracting COVID. So I'll leave it there. It's only a very, very initial introduction, as we've all said, but I just wanted to show you how we're going to use those blood tests, which you've all suffered for. You've all given me that little bit of capillary blood test, and I know it's not particularly nice. So thank you all for sticking with it and doing it. But it enables us to really get the best out of the information in this study, to hopefully feedback, you know, not just to our hospital trust that we work at, but, you know, we're tasked with, you know, informing policymakers about what should happen with the results from COPE. Thank you very much. Back to you, Payman.
Thank you so much, Alex. That was really interesting. And I see that we've got quite a few questions. So I'll pass over to Kuli and Di, if that's okay.
Thank you. Thanks, Alex, for a great presentation. Some of the questions I think she answered already based on whether we discriminate being vaccinated and being not vaccinated. And one question that has come in is that somebody haven't received antibodies along with some other colleagues during the study, and was wondering why was this? Is there anything we can answer through this webinar?
So it could be if they took part as what we're calling an asymptomatic patient, then they were only people who reported a positive antigen test were sent a dried blood spot, and that was in the participant information sheet. But we've definitely had some emails into the email inbox, and that's been the explanation. So that's possible. If that isn't the case, then if they want to send an email to us, we can look into that. So that's cope-wm at.
We can write it in the chat.
We'll write it, we'll write it in the chat, and it will be circulated after the webinar. So if anyone's still uncertain, then do send an individual email in and we can look into it.
And that's really helpful. We are trying to keep a track of everyone we expect to have given us the results. But of course, some people forget to send back their samples. So sometimes it's difficult to know. So if you have sent a sample and you haven't got your result back, please do let us know and we will try and get it to you. There is the possibility that it got lost in the post. And so we can always send another test out to you. But Emma's on top of all of this, and she, you know, we work closely together on this.
Thank you. Another question, are you picking up any reinfections?
That's a good question, Dana. In this study, that's not part of the main aims of the study, but we've got other studies going on which are looking at this, and we've just been funded by the UKRI, which funded COPE as well, because they know that we've done this project. And what we're opening a study called Vibrant, and this will be open for anyone being involved in siren or in any of the other healthcare worker studies like COPE. And if you've had a reinfection and you've been picked up through that study, you will be invited to Vibrant. And we're looking particularly, we're only looking in healthcare workers, because we realise that you're a very special group of individuals in the country, because you're at high risk of exposure, which we've proven in a number of studies. So I think, unfortunately, the government thinks that we're a bit like the canaries in the mine. What's going to happen to us is probably going to happen, you know, to the general population. So look out for Vibrant. I'll be tweeting about it as well as we go forward. And, you know, a number of your trusts, all the trusts that have contributed, most of them are linked into either the COCO study or to Siren. So we should be able to get you involved in that with reinfections as well, and why that's happening.
Brilliant, thank you. Another question from Adrian. I only had lack of smell and taste in April 2020, and he was not eligible for recent testing. How many people were not isolating because unable to test?
Oh, it's difficult to know. But Adrian, you know, you've hit the nail on the head of, you know, asymptomatic infection or a lack of testing. And we certainly know it was really chaotic at the beginning in that first wave of the pandemic. And there was just not enough resource for testing. I remember spending the whole of that first Easter weekend setting up a laboratory with Andrew Beggs here to enable staff testing at UHB. And then we expanded the government's testing program, and we ran a community testing laboratory here at the University of Birmingham as well. So but now obviously we've got these massive Lighthouse Labs and Milton Keynes. So the capacity in the UK has grown enormously. I have to say, I never expected we would need to be doing, you know, the test, you know, 50,000 positive tests. You know, we're somewhere between 35 and 50 at the moment, every day for a month. So there's sheer quantity of testing. And the logistics and the organisation to administer that is just absolutely enormous. And unfortunately, that was lacking at the beginning. We saw what happened in the nursing homes as a direct result of that. We certainly know in our hospital trust, there was a significant inter-hospital transmission. So from patient to patient, staff to patient, patient to staff, that was all very real.
This is a clarification question. I didn't quite follow the point about people not showing antibodies after vaccination, and whether that was people not getting vaccinated or that for some people the vaccines weren't effective.
Yeah, no, that's really easy to answer. It was mostly that there are some individuals that have chosen not to get vaccinated yet. And what we've found in a number of studies, not just COPE, but in the COCO study and other healthcare worker rates, you know, it's kind of in 98 to 99% of people respond to vaccination. It is the most fantastically immunogenic vaccine that I've seen in my lifetime. You know, flu is somewhere around 50%, 60%. This is a really powerful vaccine, but unfortunately hasn't lasted so long. So 4 to 5, 6 months, we need this booster.
Next question. Any thoughts on the timeline of antibodies from infection or vaccine or both?
Oh, I've got quite a lot vested in this actually, and we've been monitoring a number of cohorts over time. So at 6 months following natural infection, 2/3 of healthcare workers have held on to their antibodies. So quite a good number. But obviously that's not everybody, and that's following natural infection. What we see post-vaccination is that the amount of antibody you produce post-vaccination is much higher than post-natural infection. So you start from a higher point. So yes, you'll get waning antibodies, but you don't kind of wane to below that point as far. So it's a much smaller percentage that don't have antibodies. But remember, all these antibodies are designed to pick up immunity to the the Wuhan strain. And we've got a number of studies showing that cross protection against Delta is significantly lower, especially at 6 months. So yes, certainly follow the government advice. The JCVI are asking us for all our data all the time as to, you know, what we're finding, and they are feeding that back in live. I think we hadn't anticipated that the vaccines would wane so dramatically, but there is a real hope that actually it's a dosing thing. And so waning after the 3rd dose or that booster dose may well be slower. Watch this space.
I'm going to just jut in, if I may. Thank you, Alex. I think that's generated lots of discussion, and I think we could probably carry on. And I'm happy to allow some more questions. But could I ask, whilst you're doing that, just if I could invite people to please type in any comments, and I'll go back to Alex to answer any final questions. But what we'd really like to know from all of you is, who do you think we should target with the findings from the COPE study? So at the moment, we've identified a list of people that we will send a summary of our findings to. So yourselves as participants, the managers in the trusts, unions, HR, hospital occupational health, and infection control. But if anyone has any thoughts on people missed from this list who also should be targeted for any information, please type in. I'll go back to any final questions for Alex, and then we'll stop.
I know we've got only a couple of minutes, but what I'm really happy to do is if someone can save the chat,
we'll do that.
You can respond, and why don't we circulate so I can give it a, you know, a bit of time. I'm just realizing we've got 2 minutes to go.
Yeah, that was the plan, Alex, that we'll try and respond, you know, outside this week for anything we've not dealt with during.
Brilliant.
And I see that somebody said, how will the results change, be used, and how will it change? So again, please do let us know about any other groups that you think we should make sure know about the findings. And we will be inviting some of you, as I said, to think about actions that we need to target, you know, actionable points from the qualitative study, from the interviews as well.
So we've just got a couple more questions quickly to ask.
I think there's one question, as I said, is about kind of the aim of what we are trying to get at, and also again in a chat area, there's quite a lot of recommendations, like where do you kind of send the results. It's kind of very active there, so so there are ideas coming from there. And what is the question?
And the question from a paramedic is, with PPE and being in an ambulance for hours, you know, the compromise for themselves and individuals, you know, any plans ahead for that? How do you capture the data?
About, sorry, whether for whether they continue.
So one of their concerns is the fact they're going to be in PPE with patients in an ambulance for hours.
Yeah.
On end, the risk to self and everybody else. So.
Yeah, I guess one of the things we hope to be able to pick up from the questionnaire is the extent to which PPE helps to protect, or whether there's other things that protect. But I don't think we can answer directly, you know, how, you know, what advice. Hopefully it will give us some clues as to what are the most important, you know, to what extent does PPE or different types of PPE protect.
Then how do you share with patients? Because we know that we can disseminate information to healthcare workers, but patients would be useful for patients to know.
Really helpful, thank you. Well, yeah, I think finding patient groups to share this information with is important. Thank you. Okay, I think we've come to 2 o'clock. I really wanted to thank everyone who's participated, really appreciate it. Those who will be watching the webinar and aren't here, please do send your thoughts and comments through to us as well on the COPE-WM email address for any thoughts or comments or questions. We will come back to you on it. And with that, I'm going to thank all our speakers. and Emma and Katie, who've helped to set this up, and Di and Cully as well for helping with fielding questions. Really appreciate it.
Well, I'd just like to add my thanks to Katie, who's done the most in terms of organising it. So thank you very much.
We hope to have one more webinar when we've got more final results as well, and we'll be inviting you to that too. So thank you again for coming. Okay. Let people go if they want to. Thanks. Bye-bye. Bye.
Thanks very much. I'm going to end the recording now, and we will distribute after it's all completed. So thanks for attending.